بسم الله الرحمن الرحيم. احنا دي اول محاضره هنعملها في الكورس بتاعنا بتاع جراحه التجميل، وانا اخترت لها عنوان ان هو Introduction to Plastic Surgery: The Basics of Reconstructive Surgery. اول حاجه نبتدي بيها is the definition of the specialty we are talking about. Plastic surgery is derived from the word Greek plastikos, which means to shape or mold. The recent trends in plastic surgery aims to blend form with function. There is always a debate which comes first, form or function. This is what we're going to answer shortly. Plastic surgeons or plastic surgery in general is a problem-solving specialty. It is special among other surgical disciplines that every patient is unique and is representing a different problem. It is also unique in that there is no anatomic area in the care of the patient. Plastic surgery requires manipulation of all the body tissues, skin, soft tissue, bone, and actually from the head to the toe. Plastic surgery is broadly divided into reconstructive and aesthetic surgery. We will focus on reconstructive surgery. What you will face as a trainee, you may see plastic surgery cases in the ER in the form of cut wounds, lacerated wounds, skin loss, burns, amputated parts, trauma to the face, RTA, and major composite extremity trauma. While in the clinic, as a cold cases, you will see congenital anomalies, old scars following trauma, burn, tumor resection, and also patients seeking self-esteem. In modern history, will start by the World War I and World War II. We all know that wars is always the motive for every huge step in medicine in general and in surgery in particular. The old history will dates back to the ancient Egyptians. We talk about the Edwin Smith papyrus, where the old Egyptians or the pharaohs were concerned about wound healing much. And this is actually the beginning of early attempts to do plastic surgery procedure. World War I and World War II, the world faces a lot of facial and extremity defects and deformities. We have to mention the name of the father of modern plastic surgery, Sir Harold Gillis, who said the very important dictum: plastic surgery is a battle between beauty and blood supply. This is the whole conclusion of the specialty. Gillis and Millard in 1957 put some principles called the 10 Commandments, which we are all following, and they entail that you have to diagnose before you treat. Observation is the basis of diagnosis in plastic surgery. Always look at neighbor tissues when you try to find an alternative to the missed parts. Never do today what can wait till tomorrow, although sometimes crucial, but time is our greatest ally. Simple is good, but it's not always the best. Sometimes we have to do more effort to get a better result. Try to meet patients' expectations with reality, ethics in thinking and decision making. Plastic surgeons usually analyze any problem they see by describing it as a wound, which is disruption of parts, as a defect, which is loss of parts, as a deformity, which is distortion of parts. A wound needs repair of parts. You have to respect layers, you have to respect the anatomy, respect underlying vital structures. When you consider the problem as a defect, so you need to replace parts, try to replace like with like, and you have to think about the proper donor site selection. On the other hand, if you consider it a deformity, you need to reassembly of parts, and actually in dealing with the deformity, usually you need more than one stage. We have to be careful about ethics, because we know that the Nazi physicians experimenting on the Jewish prisoners in the concentration camps, and this was behind that the oath was put, and this is the first guideline for the human experimentation in the form of Nuremberg Code. So we have the Code of Ethics, which is autonomy, includes autonomy, which is the right of the patient to choose the line of treatment. Beneficence, you always do what is benefit to the patient. Non-maleficence, try to avoid any harm to the patient. The first rule is never do harm. And then we have the distributive justice, which is the justice in the distributing the service you provide, whether it's a cash patient or insured patient. Decision making is based upon evidence-based medicine, and in concerning evidence-based medicine, we have to think about the levels of evidence. We have a hierarchy which we have to see, and then the outcome analysis is the outcome of the evidence-based medicine, and this will lead you to put the guidelines for management. And this is the hierarchy of the evidence pyramid. At the base of the pyramid, you have the more biased trials in the form of expert opinion, case reports, and series, while at the top of the hierarchy or the pyramid, you see the randomized controlled trials, which are actually very difficult to do in plastic surgery. When we think about wound closure, we have to consider the blood supply of the skin. And when you think of the blood supply of the skin, I always say, think of plexuses. We have the plexus beneath the muscle, then we have the subfascia, we have the prefascia, we have the subcutaneous, the subdermal, the dermal, and even the subepidermal plexus. This is the way how the blood supply reaches the skin. If we think about simple situations, you think of direct closure of wounds. This is what people are thinking of plastic surgeons. They are the best to close the skin. But even in very simple procedures like direct closure of the skin, there are many decisions that the plastic surgeon should make. First is the choice of the suture material, choice of suture technique, timing of suture removal, and actually at the end, the most important part is how the final scar will look like. To choose the suture material, you have many choices. You take absorbable versus permanent. You have to consider the tensile strength of the suture material, and then you think you need a multifilament or monofilament suture. Each one has its pros and cons. What is affecting the choice of the suture material is the type of suture you're going to use, the anatomical area, presence of infection, the tension on the wound closure, and then the wound healing capacity and the patient's comorbidities. Suture technique, we have a lot of techniques in our armamentarium, starting from simple interrupted sutures ending with the skin statements. When you consider the timing of suture removal, this is dependent upon the site of the wound, the type of the suture material used, and the technique used for suturing. When you think of direct closure, when there is no skin loss, it's a simple wound closure for simple skin wounds. You always try to make the wound looks like an ellipse. This is the way to avoid having dog ears, which will let you take a lot of scars to get rid of it. On the other hand, we have direct closure for more complex wounds, which require extensive undermining. You think of layer closure of the wound. What is more important is the realignment of vital structures, and in this patient is the realignment of the eyebrow. You have to respect the principles. The limit of undermining is to avoid distortion of nearby anatomical structures. You see at this patient, if you do overtension and you pull on the angle of the mouth, you will pull on the eye, you will pull on the side of the nose. You have to respect principles and always look for the deep underlying structures, and in this case, you have more important than closure of the skin is to detect and repair the fissure depth. The final scar actually is depending upon the skin tension lines, the proper suturing techniques. So we have to think of scar placement. When you think of scar placement, think of the resting lines of the skin, and this will lead you to the very important dictum, think muscle. We have to put our scars, as you look at the muscles of the face, actually perpendicular to the muscle, so that when the muscle contracts, they do not pull on the scar. If you put the scar parallel to the muscle fibers, each time the muscle contracts to pull on the scar, you end up with a wide, ugly scar. You have to, when you deal about wounds of the face, we have to think about the facial aesthetic units. Every plastic surgeon should know the facial aesthetic units by heart. And you know that every unit, for example, the nose, the lip, the forehead, the cheeks, the periorbital area is divided into many sub-units. Usually the patients will ask you, doctor, if there will be a scar at the end of this. But the answer is not in my hands. I will do my best, but actually your skin type play a very important role in the final scar appearance. So the best scar you get it in the famous Fitzpatrick classification for skin type 1, while the worst scar you get in skin type 6. The window healing is a series of dynamic interactive process which includes a lot of cellular production, and extracellular matrices are formed. The process follows specific time consequence, and it includes coagulation, inflammation, deposition, differentiation of extracellular matrix, fibroplasia, epithelialization, contraction, remodeling at the end, and the formation of a scar. If you look about the stages of wound healing starts immediately within 24 hours after injury, and this is seen histologically by the influx of a lot of neutrophils in the wound. Between 2 to 3 days after injury, there is the first appearance of the macrophages. And then 3 to 5 days, there will be fibroblasts. And for the healing of the wound, what you are looking for is the collagen deposition. So these are the 3 critical stages of wound healing: inflammatory phase, proliferative phase, and then the stage of remodeling or scar formation. And as you see, each one is characterized by certain cell type predominance. The factors impairing wound healing, we all know about it: intrinsic factors, ischemia, infection, foreign bodies, cigarette smoking, venous insufficiency, radiation fibrosis, local toxins, repeated trauma, and cancer. While in the extrinsic factors, you have the nutritional deficiencies, diabetes, chronic renal failure, use of steroids, chemotherapeutic agents, distant malignancy, old age, liver disease, other drugs, and hereditary factors. Scars, with the exception of the fetus, which we know that the fetus heals without scarring. We call fetal healing is scarless. This is the only way we don't see a scar. But every wound will end up with the formation of a scar. Scar may cause a lot of problems and complications. For example, if you got a scar in the brain, it appears in the form of seizures. In the intestine, it's a form of intestinal obstruction. And then close to joints, you got muscle loss of range of motion. This is to show that even the largest wound will have, this is the natural process that will end with scar contraction and then formation of a scar, which actually will look ugly. Scars, this is the end stage of the wound healing, and it is actually the equilibrium between collagen synthesis and deposition and collagen lysis and degradation. The outcome is the mature scar. this scar, you have to know, it gains approximately 80% of its tensile strength between 6 and 18 months after wounding, while the remodeling process of collagen synthesis and lysis can last up to 2 years after initial injury. Causes of ugly scars, we have tension, infection, improper alignment, delayed epithelialization, impaired blood flow. We have a golden rule that you have to do proper undermining using deep dermal sutures to create wound edge eversion. This is very important to have wound eversion to get a good scar or nice scar formation. This will reduce wound tension and diminish or minimize scar width. The scar is a function of the light reflection that catches the attention. So placing scars in natural creases and junction between contours will let you get the most inconspicuous scars. This is the example of a normal scar, you see it in opera and plastic. Even this is considered a normal scar, it's just a slightly white, maybe technical error. But on the other hand, you have apparent scars in the form of hypertrophic scars and keloid formation. The most important difference between hypertrophic scars and keloids is what you see here written in red, which is that hypertrophic scars should remain at the site or confines of the original wound, while on the other hand, keloids, as a rule, they are enlarged scars that extend beyond the margins of the original wound. This is examples of a hypertrophic scar, just a white scar, but this is a keloid scar which extends beyond the margins of the original incision or wound. How to prevent it? Adequate debridement of non-viable tissues, remove foreign bodies, minimize tension. Approximate layer tension is the enemy of plastic surgery. Approximate layers, fill dead space, prevent hematoma and seroma, prevent infection, remove sutures at the appropriate time interval. Scar management, we have medical management. You are all about it, aware about it. You know about silicone gel, you know compression garments, you know injection of steroids, you know the botulinum toxin recently, laser treatment, makeup camouflage. Then we have the surgical treatment, which will be in the form of excision direct closure, excision angioplasty, excision skin grafting, dermabrasion, flap closure, and more recently fat grafting. Combination of surgical revision plus adjuvant therapy is the most important thing that we consider. Scar management is a multimodality therapy. This is an example of intravenous steroid injection. This is the pressure therapy. If the patient is obedient to use it, we always get very good results. And then we have the surgery plus intraregional steroids, surgery plus radiation, and then we have talk about after that about skin grafts and skin flaps. If you talk about skin graft, this is a piece of skin which is transferred from one side called the donor to acquire a blood supply from another side, the recipient. And this process is what we call graft take. Skin defect, if it's a simple skin loss with no exposed vital structure, you always think of skin graft. And you get a very good result at the end. Indications for skin grafting: any traumatic wounds that cannot be closed primarily, defects after oncologic resection, burn reconstruction, scar contraction, congenital deficiencies of skin, and then nipple areolar reconstruction. Contraindication: we have some absolute contraindication, wound with avascular beds, and then infected wounds, wounds due to malignant neoplasia. While you have relative contraindication, you don't like to use it in pressure sores, wounds due to radiation, wounds due to vasculitis, wounds due to arterial insufficiency, wounds in cosmetically sensitive area, malnutrition. We have types of skin graft. If you look at this figure, you have you talk about split thickness and full thickness skin graft. Split thickness skin grafts taking the epidermis and part of the dermis, while full thickness skin grafts taking dermis, epidermis, and the dermis. It is the amount of the thickness of the epidermis that you take which makes you see this line A, which is the thin split thickness skin graft, line B, which is the medium thickness skin graft, line C, which is the thick split thickness skin graft, while line D, including the dermis, whole dermis, is a full thickness skin graft. Split thickness skin graft, it removes the epidermis part of the dermis, base donor side, thigh, back, abdomen, chest, scalp. You can do it with a humpy knife, you can do it with a dermatome. You have to measure the graft to avoid collection of hematoma beneath it. And then you apply a tie over to ensure fixation of the graft, prevent mobility of the graft. So this is an example of how we put a mesh graft, fix it, and this is the end result of the wound. This is another example of using skin grafts, and this shows the donor site, what it looks like. It has advantage of split thick skin graft, including availability in large amounts. It requires less bed vascularity. On the other hand, it is not cosmetic, especially in the face. You see, it's usually the color difference is very difficult to achieve, the color matching, less durable. When you talk about full thickness skin graft, it's harvested by scalpel. Possible donor site, you see it in the groin, in the arm, in the supraclavicular area, in the postauricular region, in the buttock crease. It's always remember to defatten the graft. The advantages of full thickness skin graft: better color match, more durable, no donor morbidity. While on the other hand, we have a limited donor size. It requires a very well vascularized bed to allow for the take, and then only small sizes are available. Skin graft take. These are stages of skin graft take. We have the stage of adherence, with the attachment of the graft to the bed, and then imbibition, where the serum absorption by the graft. where the graft now starts to get some nutrition from the bed, and then anosculation, where there is the anastomose between the graft and the host vessels with the appearance of the capillary buds from both the graft and the bed, and then the stage of revascularization, the establishment of a blood supply to the skin graft we call graft take. The success of a skin graft adheres to the bed by fibrin within 48 hours. Then the fibrin breakdown. This will be followed by the appearance of the capillary buds from the recipient area to unite with capillary buds from the graft. This is recognized clinically by the pink coloration of the graft. On the 4th day, collagen starts to replace fibrin. More slowly, lymphatics will start to fall. The graft can now be handled safely with care. The speed with which the graft is vascularized dependent upon the bed or bed vascularity. To summarize, a recipient bed incapable of forming relation tissue will never allow skin graft take.